Well, good afternoon and greetings from Toronto, Canada. And my sincere thanks to the organizers for the very kind invitation to speak. I'm sure you're wondering what a 19th century German philosopher has to do with critical illness survivors. And maybe I can chat a little bit about that with you over the next few minutes. I don't have any conflicts involved in this talk. I wanted to start the talk with a quotation from Nietzsche, and that is, "That which doesn't kill us makes us stronger." I'm sure you've heard this all the time. I'm never quite sure if I agree with this, but I want to talk to you a little bit about this in the context of critical illness. And I present here a young woman who I looked after a couple of years ago. A young woman in the Toronto General ICU who's about as sick as we can look after at our place, on ECLS, on lots of pressors, continuous renal replacement therapy. And I show this picture to begin with to help us to think about the continuum of critical illness. I'm sure Jack Washington is going to talk a little bit more about this later. But just to think about what lies ahead. We don't really know what preceded this, but what lies ahead, and to think about the continuum in that context. What is she going to survive, and is there any good that could come from this? Well, I want to use some pictures that our groups accumulated over the last 2 decades from two of our major outcome studies in ARDS patients and in patients who've been mechanically ventilated for a week or longer. And I show this initial picture here of ICU-acquired weakness in a young woman with community-acquired pneumonia, showing the very characteristic muscle wasting and weakness, affecting primarily the shoulder girdle and the hip girdle, and leading to a lot of functional disability. That functional disability has been quantified by ours and many other groups internationally, and captured by a decrease in distance walked in 6 minutes in the top panel here, where this woman was part of the cohort of people in their early 40s who were only able to achieve their 6-minute walk distance 66% compared to an age and sex match control population. And that was reflected also in a decrease in quality of life in the lower panel in terms of the physical component score of the generic quality of life measure, the SF-36. It's low. And the muscle biopsy here, again from a patient in this group, shows chronic myopathic changes. These are chronic changes to go along with that disability. But what about brain dysfunction as well? And the CT I show here illustrates the the age-inappropriate cortical thinning in a relatively young patient. And you see the ventricles are increased in size as a result. We know that these patients have a problem with processing speed, attention, concentration, executive dysfunction, and cognitive dysfunction in the order of a moderate traumatic brain injury or mild Alzheimer-type dementia. These patients also have mood disorders at a very high proportion, illustrated here, as well as post-traumatic stress disorder. And we know that a lot of the delusions that patients lay down as part of delirium really sets the stage for post-traumatic stress disorder. So we have functional disability, we have neurocognitive, neuropsychological disability, and we have patients who decline, on average, a general decrease in their sense of wellness, their own health, and a drop in their own vitality. And this is linked to subsequent healthcare utilization and also linked to cost. But it isn't just all about muscle, nerve, and brain. And just to show you a few other slides, there are a whole host of other issues that patients may suffer from in terms of lung dysfunction in severely affected ARDS patients with non-dependent fibrotic lung changes, and even more severely in patients whose baby lung has been exposed to very high airway pressures on a chronic basis, and you see the resultant fibrobullous disease in the non-dependent lung as well. And tracheal stenosis, which can be a very complicated pathway to recovery for sure. But what about some cosmetic changes like the disfiguring tracheostomy scar or the multi-step plastics revision after complex fasciotomies in an ECLS patient? And what about heel or occipital ulcers that are present still 1 year later because they've been colonized with multiply drug-resistant organisms, maybe fungal infections, and you can't work in slippers? Or maybe you can. Someone told me that one of the speakers gave their talk in flip-flops, so I don't know. But it's hard to work with an occipital lesion that's just oozing like this as well. So these are really major impairments in terms of trying to reintegrate back into a normal life. Or heterotopic ossification that affects the large joints, it's extra-articular bony deposition, or contractures of the knees, contractures of the elbow and wrist. So there's a whole host of things that may affect our patients. The post-complex intra-abdominal sepsis patient who still has a vac in situ 1 year later and a leaking ileostomy. But the family are the collateral damage as well. And family caregivers often present with very important symptoms of depression and PTSD. And on the upper corner there is the young woman whose picture I showed you to begin with. This is Hwin and her husband Ken and their 2 girls. They participated in one of our follow-up studies. So she looks wonderful. She's a very beautiful young woman, but she's really wrestled a lot with a lot of the things that I've described to you, as well as mood disorders. And her husband, although not as profoundly affected by mood disorders, has certainly had his own difficult journey throughout. So how can anything really good come from this? And is it just a ridiculous Pollyanna-ish thing to say that? There's certainly a lot of morbidities to get through and to wrestle with. Is there anything that could be of benefit here? Well, there are many people who feel that post-traumatic growth or the development of new resilience may be just one of those things. And post-traumatic growth is really something that I'm going to talk about a bit in the next few slides. Remember that critical illness is a traumatic life event. It's something that fundamentally changes an individual's narrative, their own concept of themselves and their family. And post-traumatic growth is really a subjective experience of some sort of a positive psychological change that arises from the struggle. But I think it's important to point out that people who note post-traumatic growth are certainly not glad that this event happened to them. The majority of people would say that they would really rather turn back the hands of time. However, we can't choose our life, and that they may have learned a lot of valuable lessons from this. But it doesn't preclude the development of mood disorders. It doesn't protect someone from depression or post-traumatic stress disorder. What are the determinants of post-traumatic growth? Well, the data, quantitative and qualitative, seem to indicate that women more than men seem to be benefiting from this. Younger versus older patients as well typically are higher income and more highly educated patients, and those people with very discrete personality characteristics are hardwired. Those people with extroversion, openness, and agreeableness to have post-traumatic growth. And what is that really? Well, post-traumatic growth is a change in your perception of yourself. It truly disrupts that narrative. You now are a vulnerable person. You're someone that bad things happen to. Your life is different. You feel that you're not invincible anymore. You've been touched by that. What are the changes in experience of relationships? Well, you may find out who your true friends are. You may find out that people really can't cope with a new mood disorder that you're wanting to discuss with them, or ask for help with a new functional disability. Maybe they can't bear seeing you have an episode of depression, or turning to alcohol or drugs to cope with that and to deaden the pain. But most people with post-traumatic growth, even though those are sad occurrences and maybe a revelation of what relationships truly are in their life, find that they are able to really affirm those relationships that are solid, that are meaningful, and that really define something central and valuable. And people define that there's a change in one's own philosophy, trying to really find what is a priority, leading the life they want rather than the one that's expected of them, and really trying to take that path, make those difficult choices, maybe chart a new course for themselves. Preparedness and resilience. Well, preparedness is really the ability of transformed assumptive worlds, these new worlds, to resist a subsequent trauma. That's really what we're talking about. We're talking about the ability to bounce back from a psychological earthquake when it recurs, if it ever does. That's what preparedness is. And it's that preparedness that really provides the opportunities for resilience. It's that invaluable learning. So maybe Nietzsche is right. When you get through a struggle and a crisis, as an episode of critical illness is, maybe the opportunities for personal growth, post-traumatic growth, preparedness, and resilience may be one thing positive that has come from that. And he goes on to say that he who has a why to live can bear almost anyhow. And I would say this is just another shout out to each of us to make sure we know our patients and families and help people to understand the continuum of illness and recovery, to understand the spectrum of disability and challenge, to make sure that the treatment that we deliver every day in our critical care units aligns with the goals and values of our patients and their families. We need to know them to understand that and to make sure we really value and honor that alignment. Most people say that their family is what keeps them going when they have a difficult time. But it's important to know, for example, does someone like to sail or hike or garden? Or I just had to put in a little plug for the Canadian sesquicentennial. Maybe you want to visit Canada. You don't know. Whew. Anyway, but it is important. It is important, and it takes time to communicate. It takes time to know our patients and families and to educate about some of the things I've just shown you, and mostly to listen. A lot of people through this wonderful meeting have been emphasizing listening, emphasizing silence, emphasizing the importance of communication and education, and also the humility that goes hand in hand with doing what we do every day as intensivists, because there is a lot of uncertainty. So just to close with this last slide and urging each of us to educate ourselves about who the patient and the family were before, to educate ourselves about the continuum of critical illness, what morbidity looks like, what recovery looks like, what the challenges might be, to understand, again, the disability resilience growth potential, but not sugarcoating that. These are traumatic life events. To align your treatment with the patient's goals and values and to know that person and their family, to listen, to try to sustain hope, and to be very honest, above all, about uncertainty. David just mentioned the same as well. And to remember that we're really partners with our patients and families in this journey. It's a great honor and a great privilege to do the work that we do, and to really engage with folks and to be part of that. Thanks for your kind attention.
Alex, do we have questions?
We do. This is a good one. Has discovering so much about what happens to patients after ICU affected who you treat and how long you treat them for?
There's one to go.
Well, I think that when you spend a lot of time doing follow-up work, it completely transforms your lens. I think it transforms how you look after patients, and it transforms how you see them in a bed. I think that you begin to see people more on a personal level, and their families as well. I think that it has changed my practice a lot. I think I try to be very careful about 4 or 5 days into a critical care stay when I can see that the patient's becoming a more and more complex patient, that I understand a lot about who the patient was before they got sick, have a better sense of the sorts of resiliencies they may or may not have, and make sure that I understand clearly from the family, if there's family present, what values that patient really had, so that as time goes on, if we're getting into a situation with more and more complexity and probably more disability, depending on the patient, that we have more and more frank discussions about the possibility of not being able to return to those valued activities.
Go ahead.
More? What measures should ICU departments in their hospitals take to help patients with the psychological effects of their admission?
Well, I personally think that we should be invested in longitudinal follow-up. And there are many people struggling with trying to find metrics to show a significant benefit. But I think for those of us who are doing this sort of work, and I think invested in the hypothesis that these follow-up programs may be of some tangible benefit, I do think that we need to identify at-risk groups, to offer surveillance, to offer access. I would say in Toronto, embarrassingly, in Canada, I mean, it's very hard to get access to mental health resources. They're not as available as you might think, and as you would hope. And often you need an advocate on the inside to really help access some of these very important interventions. So I personally think that we have a responsibility to do this. It's complicated, it requires an organized system, and I think that many groups around the world are working toward that currently.
So thank you, Margaret.